So my name is Christina Puchalski. I'm a physician, palliative care and hospice. I'm also a professor of medicine at George Washington University, and I founded an institute called the George Washington University's Institute for Spirituality and Health. So I'm still seeing patients and I still teach, but I'm really passionate about the integration of spiritual care practiced by all clinicians in conjunction with chaplains and faith-based leaders on behalf of the patient to really address the spiritual issues of patients. When I started this work, I was a medical student actually, and it started as an elective. And a number of the attendees were wondering, what is spirituality? Is it religion only? I'm not religious, does this fit? So a lot of my learnings early on, it's actually the way I was raised, is to be respectful of everyone where they are, regardless of whether they identify with a religion or whether they identify with something more personal meaning and purpose. So our elective was really broad. I mean, we had people who talked about faith-based initiatives and research. We had laughter as spirituality, which is actually rooted in the word selig, which is, silliness and also holy. It's related to that. So, a lot of different topics. And over the years, as I did more and more of this work with physicians, I started interacting with others and chaplains. I discovered what healthcare chaplains do, and that there were very few healthcare chaplains in hospitals. So I became a real advocate. I learned about them, and then I said, we really need to be working together. And nurses and social workers and others, so we've really evolved over the years to interdisciplinary models or interprofessional models of how we practice spiritual care. My interest really was how do we make that part of clinical care, not just a nice conversation to have on the side. Oh, by the way, is this important to you? But really, how do we make it integral to people's well-being? So there have been models of whole person care which address physical, emotional, social, and spiritual since at least a century. But Paul Tournier's work is amazing from the 1950s through 70s. He really did a lot of work, but earlier than that actually. But often it's the spiritual health that gets neglected. So when I went to medical school, we talked about the biopsychosocial, but not the spiritual. So I was curious, why is that? And that's what started this journey. And personally, I think it's such an important part. My family came from Poland. They survived World War II. Their stories were, heart-wrenching and inspiring. And I think it's their inner strength, their understanding of the transcendent and their religious faith that really made a difference. So, and I see that in my patients, one story after another with my patients of how they are coping with really serious illness, particularly at end of life. Where are they finding their strengths? So that's been a critical piece of what I've done. I have been called to serve others, particularly within the context of medicine and healthcare. So when I can be stressed outside in the hallways, but once I enter that room, it's sacred space. It's my trying to be present and listening fully and meeting the needs of my patient. And so part of those needs are spiritual needs. So that's why I think it's been such a passion of mine to create models that people can do that. And especially these days where the suicide rate of physicians is twice the national average, nurses, clinicians are burning out. Part of that is that they are not working out of their call. So call and vocation is such a critical part of what we do in healthcare and how we bring that into our practice. And there's studies that already show that patients, when all their needs are addressed, when they're really listened to, patient satisfaction goes up. So it's critical. And part of the team has to be the chaplain, because we work as the generalists, so to speak, and then the chaplains are the experts, and we should work as partners. So I think, I'm trying to go back to your question again. You want to know how I do that in a professional way. So part of the work was developing guidelines around spiritual care and spirituality and health. In the early part of this century, there was some research around religion, but more association studies. And so how to integrate it into clinical care, I partnered with my colleague, Dr. Betty Farrell, who's at City of Hope. She's a nurse researcher. And we put together a consensus conference that included everyone, all the clinical disciplines, chaplains, faith-based leaders of all different backgrounds. And we created a definition of spirituality, as well as recommendations for how to do that in clinical care. And that's where that generalist specialist model came up. So I did another conference several years later in Geneva, which broadened it beyond the United States to look at different culture perspectives. So we had many cultures represented at that conference. And we changed the definition a little bit to broaden that. So part of my work and others has been to define spirituality broadly as a search for meaning and purpose in a relationship with the transcendent, however people see that. So some people see that within a religious context, some people see it in other contexts. So in clinical care, it's really important to be respectful of how everybody comes to that understanding, and whether it's within a faith context or another context. And I developed a tool called FICA for how to address spiritual issues with patients. And the stories I hear are incredible. And people will bring stories of faith or stories of spirituality outside of a faith context, or what gives them the most meaning, particularly at the end of life. And so that's been a critical piece of this. And building on those guidelines, we now have a training program called Interprofessional Spiritual Care Education Curriculum that built on those 10 years of developing clinical guidelines on how to do that. So I'll change the context a little bit, although most of these stories I'm going to tell people are not here anymore. But when I was a medical student, I rotated through a hospice in Washington, D.C. And so I had developed that spiritual history too. I was a third-year medical student, and I asked this patient about what was going on with her. I did a complete history, and then I asked about spirituality, and she goes, I'm not spiritual, I'm not really a person of faith. And so I said, what gives you meaning? And she paused and said, I don't know. I don't think I have any meaning. So 2 days later, I came back to see her, and she had a completely different expression on her face. She goes, I have just been waiting for you to come. I have so many stories to share. Because after you left, I started thinking, actually, I've had a lot of meaning in my life. And for her, her journey started in a faith-based organization. She moved a little bit away from that. Her life was one of service, and it was just remarkable to see that. And I think it was really, for her, helpful. And at the end, she says, I think you're going to do something with this. I think you're going to teach others. She goes, tell people not to wait till they're on their deathbed to ask about what matters most, what gives them meaning, whatever context that's in, whether it's within faith or other contexts or family or nature, how people come to understand, or service, how people come to understand that in their lives. And another story, really, and I'm so passionate about this, is my mother lost her first husband during World War II. She had escaped and she had a son. And so she was depressed and went to, this was during the war, went to see a psychiatrist, and she talked about her pain and her suffering. And he showed her a Rorschach ink blot. And she looked at him and said, I don't need to, to look at these pictures. I need you to listen to me. I'm really hurting. Can you help me? And he didn't know what to do with that, so she left. And there are numerous stories like that I have seen. Again, in medical school, I was taking care of a patient who was probably end of life, but at that time, we didn't have such an awareness as we do now. So I came to see her, and she had a room by the nurse's station, but they moved her down at the end. And I said, why did you move her? Well, she's in that place, she needs to be alone. So I walk into the room, and 4 beds, 3 empty, she's laying in one, and you could feel the suffering. You could just feel it when I walked in that room. So I sat next to her, and she was just laying there, and I sort of touched her shoulder, and how are you today? And she just had a really hard time talking about things, and then she started crying, and I just sat there and I listened to her. I didn't say a word. I was fully present to her, and she got out what was really bothering her, and even the fact that they moved her to this empty room. She was alone. She hadn't reconciled with some family members. She was a person of faith, and nobody from her church had come to visit her. And so she just talked, and I listened. And I was extremely moved by it. And just sat there in silence, and she said, thank you for this. I just needed to be heard. Right? So I think a lot of our work in addressing spiritual distress is about being present. And it is hard to be present to deep suffering. There's a Maryknoll sister who was also a doctor, who a colleague of mine is a Maryknoll priest, and he actually works with us, Father Rick Bauer at GWISH. And what she had taught him was our role is to stand in the face of massive suffering and not run away. That is what spiritual care comes down to. It's being in a sacred space with patients. It's not trying to fix something that's unfixable. It's being present. It's offering our presence to patients and continuing to accompany them through different times. That's what spiritual care is about. It's holy ground. Well, that's a big question. So so part of the work that we've been doing at GWISH, and I love to collaborate. So we've collaborated with faith-based groups, with other types of groups, with nurses, all the different disciplines. I think it's such a key that this is created together. And so, the work that we started, in the early part of this century is now, there are people all over the world that are doing research in this area. Religion, spirituality, however people understand that. And I do want to just go back, because there is often this kind of work, people often will say, well, there's religion in health and there's spirituality in health. They're not different. If some people express their spirituality or their relationship with the transcendent through faith. Some people find comfort in that. Other people do it in different ways, and have incredibly powerful spiritual experiences. So even if you look at the faith development, within faith development and all the stages, we go through many stages in evolution. We don't just in our own personal evolution through life. So it's really important to be thinking about where is that person in their life, in their faith and or spiritual journey. I think that's key. And the other piece that often is so important is the notion of the sacred in the room. I think in terms of why clinicians should do this, I learned from an Indian physician. He'd been in the States, but he came from India. My very first rotation as an intern was in the CCU, Coronary Care Unit. So he taught us how to examine the patient. He says you use all your senses, including the intuitive. So for me, my understanding of intuition is connected to the Holy Spirit, okay, to God. That's the way I understand it. But people can understand it in different ways. It's in that space of being still and being quiet that we can really be open to what is going on internally in the inside of that person, in their spirit. I think that's such a key piece. And it's hard to teach that, but I think through experience you can. So we've created an initiative called Advancing Spiritual Care, which is clinicians and chaplains and faith-based leaders partnering together to advance this field. And that's through educating the workforce in how do we practice spiritual care. And our course actually invites clinicians to bring chaplains, or chaplains to bring clinicians as pairs from the same institution to learn how to do that together and go back and be leaders. I think it's so important that we work together. And we're really working to see how we can do that with faith-based leaders as well. And then the second is doing demonstration projects, which are like quality improvement projects of how does this work. So we have 5 fantastic sites right now doing incredible work in showing what happens when a patient comes into the clinic or the hospital. They get a spiritual screening by a clinician. If they identify spiritual distress, that's an urgent referral to a chaplain. The patient still goes through and sees the clinician who does the spiritual history, and then that clinician may work more on that spiritual distress and say, this person really, we need to work with the chaplain. Now the chaplain sees the patient. And feeds back to the clinicians so that they're working together on behalf of a patient. So it's really a team approach. So while this movement is so exciting, what do we have happening though in the world, right? There is tremendous bureaucracy and corporatization of healthcare. So we have to meet sort of the expectation of showing that this actually makes sense. That's why we're doing this research. This makes sense for patient outcomes. That's what that research is about. And it's really important for patient well-being and clinician well-being, right? Our physicians, as I said, are committing suicide or burned out. People are leaving by the droves. Hundreds of clinicians have left, more probably. So it's about us practicing from a place of meaning. And if you have stressed clinicians, they're not going to go there. But in fact, they need to go there to find that sense. So our ISPEC course is really part retreat and part training, because that reflection rounds that we've developed of really reflecting on what our call is so essential. And on the horizon, we have artificial intelligence. So can you imagine being asked about your suffering by a computer, by a robot? People are telling me, I keep saying that's never going to happen, but my IT colleagues are saying, yeah, in fact, that will. Patients will be interviewed by a computer. There is nothing that can replace the human relationship, nothing. It's in those relationships that people trust and share. And that woman, when I was a student, she trusted me. We need to create advocacy for healthcare to be faith-based and spiritually based, however people see that. Healthcare in this country started with faith-based organizations. Catholic sisters coming over here, hundreds of years ago, starting serving patients. We need to bring that back, but bring it back into this century, into a way that will work in this century. That's what I'm passionate about. So, as I mentioned, my parents were from Poland, and so I was raised a Catholic and in Southern California, just a really unusual environment. But fortunately, my parents, especially my father, were very interested in different faiths. So I grew up just learning about different faiths. And again, a story of my dad that was really powerful to me. Coming back from church one day, I was maybe fourth grade, maybe third, and I was very upset about the one holy Catholic and Apostolic Church. And so my father said, "Why are you so upset?" I said, "Because Suzette, who's Protestant, won't be in the same heaven. What about Rachel, who's Jewish? We won't be in the same heaven." So my father put his arms on my shoulders. He said, "It's Catholic with a small c, which means universal. There's one God, and everyone approaches that with their own unique perspective." And I think that I know that really underlies my commitment to listen to everybody's story and be respectful of everyone. Hence the broad definition of spirituality. We need to have our voice in those circles, or it will grow ahead of us and we'll be left behind. And now people are really in spiritual and existential distress right now. It's a crisis of spiritual distress. Now is the time that we have to be present. We have to address that. And one of the outcomes, if you will, of the pandemic is that we all experience spiritual distress, uncertainty, fear. Am I going to die? Am I going to get sick? Is my loved one going to die? Am I going to infect my loved one? We experience that. That's what people are experiencing all the time. We need to shine light on that and be in listening circles, respectful listening circles, and learn from each other. I think that's so important for our evolution.